Okay. Make sure I got this clear. Hello, everyone. I know y'all probably don't want to sit through this after that test, but we will get through it. If you have any questions, please let me know. The slides, Dr. Hall posted them yesterday, and the evaluation tools as well. So when you have time after today's lecture, if you'll fill out that evaluation, the same way you did it last week, according to the last name. Okay, and so Dr. Hall did tell me that 10 of you guys had the postpartum hemorrhage simulation yesterday, so you should have a lot to contribute to today's lecture. Okay. All right. Okay, so when thinking about after delivery care, the perception postpartum, patients typically think it's a low risk period. Once the baby's born, they don't have to deal with anything additional, but that is not true. Nurses must recognize that the postpartum phase involves altered health and requires vigilance and attentive care. There are potential complications like preeclampsia, eclampsia, and HELLP syndrome. They can be at risk for those up to 42 days after having a baby, which is about 6 weeks. Since 2014, the National Partnership for Maternal Safety has established criteria to assist clinicians in recognizing and managing various obstetrical issues. And so their key focuses are obstetrical hemorrhage, severe hypertension, safe reduction of primary C-sections, cardiac conditions in obstetrical care, care for pregnant and postpartum individuals with substance use disorders, postpartum discharge transition, and sepsis in obstetrical care. So you may have seen this when you are in clinical, the maternal early warning score criteria that's listed in the flow sheet. So there's things you would list, like in the flow sheet will calculate that early warning score for you, and the purpose of that is so that interventions are started sooner than later. Objectives for this chapter, we will correlate the maternal early warning score criteria established by the National Partnership for Maternal Safety, identify the causes of and assessment of postpartum hemorrhage, discuss the signs and implications of hypovolemic shock. We will discuss the different types of thromboembolism and distinguish the causes and clinical manifestations of the various types of infection postpartum, and then we will also go over postpartum mood disorders. All right, so you've got key terms. I know you were probably studying yesterday and not had a chance to look over these, but some of these you've already seen, like acne, you're familiar with that. Coagulopathy, you should know what that is, a disorder in which the blood's ability to clot is impaired. And there's a couple of new terms that you may not have seen, but we'll go over each one. So first, you've got postpartum hemorrhage. The typical blood loss for a vaginal delivery is 500 milliliters. For a cesarean is 1,000. The definition of postpartum hemorrhage would be anything above those, that normal range. So that would be anything greater than 500, anything greater than 1,000. So a major postpartum hemorrhage would be greater than 1,000, severe over the 2,000 milliliters. Has anybody seen any postpartum treatment or interventions in clinical? You have?
Yeah.
How can you tell us about it?
It was a lady, she had a C-section and she was still hemorrhaging afterwards, the C-section. So they gave her Pitocin to try to stop it. That wasn't working, so they ended up inserting
The Bakri or the
Cytotec.
Yes,
Cytotec, okay.
Yeah, and she inserted it rectally.
Okay.
And, that helped her a lot. That's all.
Okay, okay, and that's some of the interventions. The Bakri balloon one is what I was talking about. Is a form of a tamponade that they sometimes put in as a last resort when they can't get the bleeding to stop.
I think that was on our simulation. They gave like a rectal medication. I can't remember the name.
That was the
That's the same.
Cytotec.
That's Miss Protocol or something.
But
Mhm.
why
Another name
did they
for
give the
Cytotec.
rectal one and not the oral one? Because there was more than one like route on the sim.
That can act quicker than something that you put in your mouth
Okay.
rectally.
All right, and our types of postpartum hemorrhage would be primary, which is that occurs within the first 24 hours after delivery. The secondary is when when that postpartum hemorrhage occurs 24 to 12 weeks post-delivery. But it's more common in that 1 to 2 week postpartum period for the secondary. All right, so causes of this would be, wait a minute. Okay, so uterine atony accounts for 12% of cardiac output. Normal hemostasis would be after the placenta delivery. Hemostasis is maintained by uterine myometrial contraction and clotting to compress the blood vessels. We know that uterine atony, coagulopathies, and trauma are what contribute to postpartum hemorrhage. So to discuss uterine atony further, we know that, well, can somebody tell me what uterine atony is? I know it's right up there, but what can you tell me we did talk about it last week. Go ahead. Oh. All right, go ahead.
It's just the uterus doesn't continue to contract after the birth.
Right. All right, and some of those causes could be infection of the placenta, and also polyhydramnios and multiple pregnancies and macrosomia. Can anybody think of why the polyhydramnios and the multiple pregnancies and the macrosomia would increase the risk for uterine atony?
Expands the uterus so much.
Right, exactly. And the treatment would be initial management includes firm uterine massage. We talked about those, and administration of uterotonics would be medications like, what would that be? Uterotonics.
Like
Mm-hmm. That's one of them. All right, and you got risk factors would be prolonged or rapid labor with or without oxytocin, medications like MAG, and certain anesthetics. All right, and then we know that subinvolution is incorrectly used interchangeably, but refers to the uterus failing to shrink at the expected rate. So for coagulopathies, we have it's that disorder that impairs the blood's ability to clot. It can cause postpartum hemorrhage. It may result in a loss of clotting factors and complicating bleeding control. It has to be identified through lab draws, and you would be looking at your clotting factors, your hemoglobin, hematocrit, those values. We've got two different types. It can be congenital and acquired, which would be immune thrombocytopenic purpura and the von Willebrand disease. So with von Willebrand disease, it's the most common bleeding disorder, and it's inherited or acquired. The key feature with this is they are missing the a critical platelet for binding. The symptoms would be skin bleeding, easy bruising, extended mucosal bleeding, heavy menstrual bleeding. So to diagnose this, they would do those lab values to test for that antigen and the factor VIII activity. All right, for treatment options, you would do things like desmopressin, antifibrinolytics like TXA, and other medications. For ITP, which is the immune thrombocytopenic purpura, there's a primary and there's a secondary. Primary, there's no associated conditions, and with the secondary associated with things like lupus and hep C. You would see that the patient would have petechiae, purpura, nosebleeds, and potential for severe bleeding. And then the diagnosis would be isolated thrombocytopenia with no signs of DIC or severe preeclampsia. Treatment would be platelet transfusions, corticosteroids, and worst case scenario, they would have to do a splenectomy. For the neonatal impact, they will do serial platelet assessments on baby, and there could be maternal IgG that may cause transient thrombocytopenia with the infants. All right, and so lacerations and birth injuries can also cause postpartum hemorrhage. From the incisions at for C-sections, uterine rupture, lacerations during labor and delivery can also lead to postpartum hemorrhage. A firmly contracted uterus with continued bleeding. So what that means is if the patient is still having all this bleeding and you assessed the fundus, it's firm, it's midline, and it's where it's supposed to be, then this is where you want to look for other things like trauma due to lacerations and uterine rupture. So the risk factors would be rapid birth, operative vaginal birth. So like that would mean forceps or other tools they would have to do to help get baby's head out if baby's stuck in the canal. Maternal genital varicosities, macrosomia, which is a big baby. We've talked about why that would affect postpartum hemorrhage, abnormal fetal position and presentation. So uterine inversion is the fundal prolapse into the endometrial cavity, leading to hemorrhage and shock. There's acute, subacute, and chronic. The acute happens within that 24 hours. Subacute is 24 to 48 hours. And then the chronic is a month or more. There's different degrees for uterine inversion, ranging from 1st to 4th. And there's risk factors, which would be like cord traction, macrosomia.
Is this another name basically for like uterine prolapse? Are they the same thing?
No. Dr. Hall, is that correct? So uterine prolapse and uterine inversion are two different things. Or would you consider that?
I consider it to be the same.
Okay.
Yeah, because it's still
Coming out. Yeah.
Yeah.
All right, so with nursing actions, you would want to call for help, discontinue the uterotonics, establish IV access, which you should already, if you're at this point with a uterine inversion, you should already have IV access, but you may need one more. Prepare for blood tests and blood products, and immediate uterine replacement may require relaxants, surgical intervention if needed, and then there may be some oxytocin administration. So the prognosis for these patients, the outcomes differ based on etiology and blood volume lost and mild anemia. So you would, if there's a patient that is experiencing PPH, so you can anticipate that you would either be doing iron infusions or blood infusions. Hypovolemic shock could occur, and death. Patients may have a higher risk for subsequent deliveries, and you may or may not have seen this in the labor area, but once you admit a patient, there's a screening for postpartum hemorrhage risk. So next time you're in a clinical setting, just take a look at those questions that they ask every patient. For your assessment, they would vary based on the blood volume lost. So Just keep that in mind. Secondary PPH is typically less acute than a primary PPH. So, and what they mean by that is the secondary PPH is usually once patients have already discharged their home. They may notice that they're passing some clots that are bigger than a golf ball, and they're soaking through a pad, but they're stable. They can get to triage and be seen, and maybe have to have a DNC or something like that. The acute is always going to happen when they're inpatient, less than that 24-hour period. You want to monitor for status changes indicating PPH even without visible vaginal bleeding. Immediate actions for suspected acute PPH would be you want to assemble the emergency team. There's usually a postpartum hemorrhage cart, and I think Kelly went over that postpartum hemorrhage cart with some of her clinical students. And so everything you need is typically in that cart. You want to activate the emergency call system. If alone on the postpartum floor, you want to assess the uterus. You want to inspect for lacerations. If the uterus is firm, you want to perform ultrasound. That would be your provider that would do that. But if you're anticipating that they may need to do an ultrasound, you can have somebody grab it and make sure it's there. You could suspect endometritis if the uterus is tender, if there's malodorous discharge, and antibiotics would be indicated. Provider may order labs for clotting disorders and other additional testing. So these are some of the symptoms that you would see this is in your textbook. I just added it in your slides for reference while you're studying. But you see the symptoms here depending on what level of blood you lost. So being able to recognize abnormal vital signs and making sure you're noticing the symptoms in your patient. There's a lot going on during the postpartum time. There's usually a lot of family in the room and a lot of other providers in and out. So just making sure that patient is your primary focus and you're paying attention to those symptoms. All right, so managing an atonic uterus. So you always want a firm massage for a boggy uterus, may express clots and temporarily increase the bleeding after you've gotten those clots out. Bladder distension contributes to uterine relaxation. Empty bladder via voluntary voiding or catheter as a last resort. So first line would be oxytocin. You've got, it says establish an IV access, but we know that. Consider methergin, hemabate, and then bimanual compression. That is something that the provider would do. And what do you all know about bimanual compression? Does anybody know anything about that? So that's when I don't know if you've seen, I know I saw a box of them in the nursery at Novine. It's those long gloves that go all the way like up to their elbow. So you'll see providers, they'll be doing a fundal massage and they'll have one hand inside the uterus and they'll assess for clots or any other tissues that they may find inside of the uterus. And so at that time, that's when you want to make sure your patient's not in pain, or you're managing or making every effort to manage their pain. Your surgical options would be the uterine tamponade that we were talking about earlier, which is packing or a balloon to put pressure on those blood vessels in the uterus, and those usually stay in place for typically about 24 hours. The provider is present when they remove that. And it's a Bakary balloon, and there's a new one that they're using. I think it's called a Jada, I think. I'm not sure, but that's a new one that they're using now. It used to be the Bakary. Let's see. Hysterectomy would be the last resort if they can't get the bleeding to stop. And then the surgical evacuation, that's more or less your like a DNC. All right, so nursing management during the postpartum. I'm sorry?
Would they do the DNC first or hysterectomy?
No. They would do the DNC first.
Okay.
I mean, I feel like at that point, they would already know whether they need to do the DNC or
Yes.
once they've done that bimanual compression and given all the oxytocin and methadone, all the things, then they have to determine whether they need to just clean things out or if they need to just remove the whole uterus. All right. Okay, so you want to make sure you're administering oxygen during this time, monitoring if it's necessary. Monitor urinary output, and that would be placing an indwelling catheter. That's per what your provider is requesting. And then, but you want to make sure you're monitoring that urinary output because of it can indicate hypovolemia if they are not putting out the adequate amount of urine. So CBCs and coagulation studies are definitely what you want to keep your eye on. And like I said earlier, for the anemia management, you can anticipate giving iron. Their postpartum patients are usually discharged on iron if they've had a low hemoglobin during their admission. And like this says here, consider IV iron for those who cannot tolerate oral doses. And then blood transfusion is usually if the hemoglobin is less than 7. And hematoma is another reason for postpartum hemorrhage. You've got, so a hematoma is the collection of blood outside of the blood vessel. It's rare. It's usually commonly linked to episiotomies, lacerations, and operative deliveries. So, for example, like the forceps, once they has anybody seen forceps be used in a delivery? Okay. Does anybody know what they look like? Okay. So it's like metal tools or whatever, and it goes in and they encapsulate or go around baby's head. And so a lot of times it can cause trauma to the tissue around those forceps because they kind of have to maneuver it in a way that they're not hurting baby as well. So after delivery, once they usually a few hours later, you may see that hematoma pop up. It might not be right after that, but it could occur later once, like on a postpartum unit when they're being assessed. It usually develops within 24 hours post-delivery and are acutely painful. There's the vulvar hematoma, vaginal hematoma, and then the retroperitoneal hematoma. If uncertain, there can always be an ultrasound done, a CT scan. CT scan is less common to be done. It's usually diagnosed by visual assessment. Bleeding type could be venous or arterial. For care considerations, you want to make sure that you're giving anal G6, ice packs, and a Foley catheter may be needed just depending on how bad the hematoma is. And the retroperitoneal hematoma typically requires surgery or embolization, and but there can be some conservative measures just depending on this case by case. Hypovolemic shock, and that is the life-threatening condition that's caused by uncontrolled hemorrhage leading to inadequate organ perfusion and oxygenation. So it can be triggered by significant loss of circulating blood. And for your signs and symptoms, you want to make sure there are non-specific clinical manifestations. Look for combined indicators with the hypovolemic shock, like your vital signs. Vital signs are going to be a big one. The mental status of your patient, whether they're restless or confused. And it may indicate cerebral hypoxia. Pulse ox should be, you should have all this on your patient throughout this, if you're suspecting this, the cuff phone, the pulse ox machine, all those, so you can be continuously assessing their vital signs. Significant BP drop may be evident of until 25% of blood volume is lost. You need to be regularly monitoring your patient, and sometimes the continuous ECG is required. For initial management, to restore circulating blood volume and identify the source of bleeding, administer normal saline or lactated ringers, and provide oxygen. If hypovolemic shock is suspected, you're immediately going to call for assistance and establish 2 large bore IVs. these are your vital signs that you're, for hypotension that you would want to, the ranges you would want to be aware of. You're going to see tachycardia as a compensation, the body's way of compensating. Tachypnea, oliguria, which we talked about, mental status changes, and you're on the skin, you would be cool, decreased turgor, clammy, and slow capillary refill. So with, like I just said, the immediate action is going to be to call for assistance and make sure your patient has 2 large bore IVs. Do you all know what, can anybody tell me what gauge a large bore IV would be? It's typically starting at 18 if you want to administer blood products, and anesthesia usually likes you to start at 18 gauge for large bore. All right. To manage hypovolemic shock, you want to start with fluid resuscitation management, and that would be the LR or normal saline, depending on what your provider chooses. You want to manage urinary output. You want to make sure it's 30 mLs or greater per hour. If it's less than that, it can indicate continuing hypovolemia. And then again, we're regularly monitoring your vital signs. For blood transfusion, you want to follow your institution policies. So the good practice is to, if you've got a patient and you've got to administer blood transfusion, it's your first time doing it, it's not a lot of people on the floor to help you, or the charge nurse is busy, always refer to your policies or because sometimes they'll have like a Lippincott manual attached to the policies. Just print that out, and the policy is gonna give you step-by-step what you need to do for that patient. How often you need to monitor the vital signs, what rate, all of those things. So if all else fails, always just print that out for yourself to have as a reference. Always use filtered IV tubing, and always want to only use normal saline with your blood infusion. And then the common rate is 1 to 2 mLs in the first 15 minutes, because has anybody ever been with the nurse when they're administering blood products? You have? Can anybody share their experience on what the process was like, if you recall? Go ahead.
Before she gave the blood product, she got some vitals, and then she stayed with them for the first 15,
Mm-hmm.
and then she came back again for the second 15. Well, really for the first time, she was really just making sure that there weren't any changes in the vitals.
Okay. So what she said was, they typically do that first set of vital signs. You stay with the patient for those first 15 minutes, because if they have an anaphylactic reaction, you want to be present for that. You don't want to just hook them up and leave on out. And sometimes your providers will order pre-transfusion medications like Tylenol and Tylenol and Benadryl to combat those possible side effects. All right, and let's see, for monitoring, you want to closely observe that patient for that first 30 minutes. So for that 15 minutes, you're right there. It really just depends on your policy. So 30 minutes is a safe rule to just stay in that room with your patient, make sure that blood's infusing and that they're not reacting to it. Listen to the lungs for fluid overload. And for thromboembolic disease, you have venous thromboembolism, which is VTE, and that's blood clots inside of the vein. And it occurs in 1 in 600 pregnancies, and pulmonary embolisms account for about 9.2% of maternal deaths in the United States. All right, and so your risk factors for your VTE would be urinary tract infections, multiple gestations, over 34, obesity, diabetes, varicose veins, and inflammatory bowel disease. In the postpartum period, your risk increases 2 to 5 times, persisting for about 6 weeks. And that's it for that one. So the prognosis for this would be, if it's not treated, it can lead to myocardial infarction. It can lead to stroke if it's not treated. and pulmonary embolism. So similar to a person who's not postpartum or a non-pregnant person. So the assessment for DVT, that would be, it commonly occurs in the lower extremities. It may be bilateral or in the right leg. The iliac vein DVT is more frequent in pregnancy and postpartum, and the symptoms are swelling, diffuse pain, localized redness, warmth, and tenderness. And the symptoms may extend to buttocks, lower abdomen, and back. The superficial venous thrombosis is more common than a DVT. It's typically benign, but the symptoms are kind of similar, but the vein may feel cord-like. All right, perform a simultaneous leg exam for comparison. We talked about the Homan sign not being a reliable diagnosing tool. We talked about that last week. So the clinic, and we also mentioned that the clinical exam alone is not sufficient. So they'll do D-dimer, ultrasound, and sometimes they'll even do a MRI or a magnetic resonance venography. Okay, your assessment for pulmonary embolism. This is the patient that I talked about last week, the one that I did a home visit on, and when I walked in, she had all that dyspnea and coughing and couldn't hardly talk. So this is what that pulmonary embolism would look like. It's pretty obvious when they're in the late stages of it, and so there would be that difficulty breathing, the coughing, the sweating, the pleuritic chest pain, and occasionally hemoptysis, and that would be blood in the sputum. Acute onset of symptoms warrants careful evaluation. So it's a medical emergency. They need to be seen right away when they're having these symptoms. They'll be getting ABGs, D-dimer, an echo, and probably an admission to the ICU. And definitive diagnosis requires a ventilation perfusion scan, CT, and other imaging may be ordered as well. So your treatment for the DVT would be I tried to put this in order that it made sense, but your book has it in order. I put it in order of your book, and so it kind of flip-flops when it talks about these different disorders. So the superficial thrombosis, treat with supportive measures. The DVT, if it's asymptomatic, you want to just monitor with serial ultrasounds and treat if the clot grows. And then the symptomatic one, they'll typically treat with anticoagulants, like your warfarin, Eliquis, different medications that way. Just depends. I've seen them order Lovenox as well. Initial anticoagulation, postpartum, duration is up to 10 days. And so sometimes they'll do heparin, and in different forms, and then there's also those are the generic names for Eliquis and I think that's the other one. Eliquis and what's up, Dr. Hall? What's APIXBAN? That's which one? Xarelto. Thank you. That's what it is. Xarelto and Eliquis. All right, and so you may see that ordered, and then after 10 days, continue for about 3 months or switch to warfarin, and it's safe for breastfeeding. And let's see, that's pretty much all we need to cover on that slide. And for the PE, the treatment for that, we talked about that being an emergency. They will be anticoagulation treatment will be initiated, and the preferred anticoagulants would be sub-Q low molecular weight heparin, IV unfractionated heparin, or sub-Q unfractionated heparin. And the duration of therapy is typically about 6 months postpartum. Like for example, that patient that I talked about, when I followed up with her a couple weeks later, after that, she was still taking that Lovenox, so she'll be on that, well, she was on that for a duration of time. All right, so for supportive measures for DVT, positioning, elevate the affected leg to waist level. You want to apply warm or cold compresses for comfort, administer NSAIDs as needed, and using stockings or compression devices, and always encourage early ambulation. And that will, wait a minute, hold on. Encourage early ambulation because that's going to prevent those DVTs from occurring. Hold on, I don't know how I got to that page. Oh, the whole thing went out. Oh, there it is. Okay. Give me a second, y'all. I got some technical difficulties going on. Yeah, but it changed my view too. Let's see. Okay. All right. Okay, we talked about early ambulation, compression stockings, and you'll also see in your C-section patients, your immediate postpartum C-section patients, the SCD pumps. So they should have those on while they're in bed. If they don't want to wear them, once they get their feeling in their legs back, just encourage them to do some leg exercises while they're in the bed, just to prevent them from DVT risk. Your vaginal patient, the patients who deliver vaginally, they should, a lot of times they'll have the SCD ordered, but if they're able to get up and walk around, once they've walked with a staff member a couple times, they should be encouraged to get up, ambulate around the unit and around the room. Postpartum infections, the prevalence for that is, hold on y'all, I gotta change my view so I can see what I've written. I don't want to see all the slides. Yeah, it's taking me to this screen, and I wanted it on the form. I'm not sure why it's doing that. Oh, there it is. Is that it? No. It's okay. I'll just have to, I can read off the board. All right. Okay. So for postpartum infection considerations, signs of infection are often nonspecific and can overlap with normal postpartum changes. So that would mean like you're shivering, which is common after birth, but also can be a sign of infection. The low-grade fever. Persistent fever requires investigation if it lasts beyond the 24 hours or appears 2 to 10 days postpartum. Leukocytosis, which is the elevated white blood cell count, is normal immediately after birth. A rise instead of a fall suggests infection. Common causes of postpartum fever would be the perineal or cesarean wound infection, endometritis, septic pelvic thrombophlebitis, mastitis, breast abscess, UTIs, and complications from anesthesia. So that's pretty much what we already talked about. And this is just going into more detail about the perineal wound infection. For the assessment, signs would be tenderness, redness, swelling. Symptoms would be purulent, yellow, stringy exudate. And remove sutures. So treatment would be to remove sutures and open the wound. They would irrigate it and allow smaller wounds to heal by granulation. Larger wounds may be sutured later, and then they will have antibiotics. This usually shows up once they've been discharged. So a lot of times when I go do the postpartum home visits, around that 1 to 2 week mark, patients are starting to complain of these symptoms, and they usually have to go in and have a wound IND, which is incision and drain, and so they'll have that procedure typically done. But if they don't require IV antibiotics, they usually get that done and get sent home with more antibiotics. And your cesarean wound infection, the prevalence is often diagnosed about 4 to 7 days postpartum, and it's higher risk if it's unplanned. The assessment would be early signs would be 24 to 48 hours after, would be the high fever, cellulitis, typically from group A or B streptococcus. Symptoms would be redness, warmth, pain, possible wound separation, purulent discharge, and then the rare findings that you would see would be necrotizing fasciitis, may be present with thin drainage and easy bleeding. Now with the necrotizing fasciitis, I saw a patient who came back in. She had to be readmitted after being postpartum or delivering. She had a C-section wound that, when they had images in the chart, it was, she had that necrotizing fasciitis on the perimeter of the wound. It was just dark. And the tissue, you could see it was all dead, and she had to have all that debrided, and they had to put a wound back on it. And she was admitted for about a week. So in her scenario, she couldn't go home and be on oral antibiotics. She would require the IV antibiotics because of that extreme infection. Providers drain, irrigate, and explore the incision, debridement if needed. Wounds are kept open and moist until granulation forms, and then they may be sutured. All right. Give me a second. So with endometriitis, it's the infection of the uterine lining. It's caused by bacteria from the genital tract, and prophylactic antibiotics reduce the cesarean risk. The risk factors for endometriitis would be chorioamnionitis, prolonged labor, multiple cervical exams, retained placenta. And so, we go back to multiple cervical exams. So, I know you've noticed that when they do cervical checks, they use a sterile glove, and so so they're not introducing any kind of bacteria into the uterine cavity. But if they're doing it all the time, like frequently checking the patient and sterile procedure is not being followed, that can introduce bacteria and put them at that risk. And that's how that would go. The chorioamnionitis, that's infection of the chorion. So if you've already had an infection in the chorion, in the endometrium is right there, so that puts you at an increased risk for that infection to spread postpartum. Retained placenta for obvious reasons. If that placenta is still in there and it shouldn't be, and it's not detached from the uterine wall, that can increase your risk for infection and postpartum hemorrhage. So let's see, low socioeconomic status, maternal diabetes, anemia, and the following, the bacterial vaginosis and group B strep. It can lead to soft uterus and hemorrhage. Complications include peritonitis, thromboembolism, pelvic abscesses, sepsis, and death. So these need interventions quickly so that you don't lead to someone having to blood clots and hemorrhaging and the sepsis and death. Assessment, common cause of postpartum fever, symptoms would be tender uterus, tachycardia, purulent lochia, flu-like symptoms, malaise, headache, and chills. The onset varies, is often diagnosed with fever 2 to 10 days postpartum. Consider other causes like wound infections and pneumonia, especially for your, consider pneumonia for your patients like the C-section ones that are not able to get up immediately postpartum. And then it would be treated empirically with broad spectrum IV antibiotics. And so for mastitis, it's another common postpartum infection, and it's caused by the engorgement. So if the engorgement's not resolved, the milk ducts have poor drainage and from nipple damage or duct compression. So the stagnant milk promotes bacterial growth, overgrowth, and infection. Risk factors would be pressures on the breast, ill-fitting bras like your underwire bras can. A lot of people don't realize that the underwire bras can cause that compression on the breast, and sometimes on the side part where the underwire applies the pressure, the milk ducts are blocked and it doesn't allow free drainage. So infrequent feedings, if they're not feeding on a regular schedule and not completely emptying their breasts when they're feeding, that could put them at a risk for poor drainage and leading to the mastitis. Rapid weaning, which would mean just rapidly ending breastfeeding. Maternal or infant illness, and that would be because if there's maternal illness, she may be separate from the baby for a period of time, which means she's not adequately getting her breast emptied, and she's not on a pumping schedule. Same for the infant illness. Most of the time when the infant illness occurs, it's because they're too tired to nurse, and it's not, and again, leads to not adequately draining the breast. Poor positioning during feeding. So poor positioning can cause, babies will feed and they will seem like they're satisfied, but latching, if latching is not adequate and they're just, what they say is suckling on the nipple and not the whole areola, a lot of times that will cause the milk not to drain properly as well. If no improvement in 48 to 72 hours, assess for abscess via ultrasound. Abscesses feel tender and fluctuant and may require drainage. Delayed antibiotic treatment increases abscess risk. Your assessment, the breast would be red. Depending on the tone of your patient, they will be red. If they're not red, they would definitely be swollen and have like a shiny appearance. It's painful, it's very painful, and your patients will probably rate 10 out of 10 for mastitis pain. They have flu-like symptoms, malaise, high fever, and may indicate bacterial infection. It's most common in the first 3 months, but can happen anytime they're breastfeeding. Initial conservative care would be cold compresses, NSAIDs, and complete breast emptying. So this type of patient may benefit from seeing a lactation consultant to show them different positioning techniques and ways to adequately empty their breast. And then if symptoms persist, they will treat with antibiotics. And so the self-care guidelines that you would want to make sure your patient knows about: frequent emptying, making sure that they're emptying their breast every 1 to 2 hours to relieve that engorgement, make sure they're taking their antibiotics, relieving their pain, and making sure they're staying hydrated as well. UTIs are also common in postpartum patients. Increased risk due to bladder catheterization and cervical exams. So all those different things being introduced to that area, the Foley catheters, cervical exams, just the delivery process itself puts them at an increased risk for that, because the urinary tract is right there in that area, so there's really no avoiding it. But the cystitis, which is bladder infection, the symptoms include urinary urgency, pain with urination, possible hematuria, lower abdominal discomfort. Lack systemic symptoms, usually you don't see those with UTIs, usually more of the pain and the urgency. Symptoms in urine tests for white blood cells or bacteria for diagnosis. So if your patient's complaining to you about these symptoms, you could just have them go ahead and give you a urine specimen before, and then go ahead and talk to your provider, let them know what the patient is experiencing, and go from there. It could lead to a kidney infection, pyelonephritis, and that would be more of your fever, flank pain, nausea, vomiting, and tenderness at the costal vertebral angle may be present. And some patients may not show cystitis symptoms. Okay, treatment. We know that UTIs are treated empirically with antibiotics, and a lot of times they'll do urine cultures as well. Anesthesia, aspiration pneumonia, and complications from that can cause infections as well. So it occurs when gastric contents are aspirated during general anesthesia, causing chemical pneumonitis or bacterial pneumonia, leading to fever, higher risk in emergencies. So say, for example, you've got an induction in, she's laboring, and all of a sudden baby has some decels, prolonged decel, and they're not able to get the baby's heart rate back up, and they're going back for a stat C-section. But mom just had a meal a couple hours ago. So that puts her at risk for, they're typically going to put her down for general anesthesia. So because if she hasn't had a spinal or epidural already placed, then she's definitely going to get general anesthesia. It puts her at risk for the aspiration pneumonia. Symptoms include low-grade fever, dyspnea, crackles, cyanosis, and hypoxemia. Your assessment would be meningitis symptoms like headache, fever within hours. If this occurs, you're going to have a lot of communication with anesthesia or the CRNA. They're going to be right there with you in the PACU, being able to assess this patient as well. Epidural abscess symptoms, severe back pain, a shooting type pain, weakness, sensory changes, bowel and bladder issues, and fever may be present. The treatment for aspiration pneumonia would be tracheal suction, pulmonary support, and antibiotics if bacterial. And aspiration and drainage, antibiotics for epidural abscess, and then meningitis would be antibiotics as well. C. difficile infection. I'm pretty sure everybody's familiar with this and you've heard it in other courses, but this is also another possible postpartum infection. Symptoms could be low-grade fever, lower abdominal pain, which sounds like it could be a symptom for a lot of the things we've already talked about, watery diarrhea, and diagnosis is confirmed by sending a stool sample to the lab. You would discontinue antibiotics, and the first line treatment would be, because C. diff is not treated with antibiotics, so you would discontinue those. And first line would be oral flagyl, and then severe cases may require a stronger, if it's severe, they will go with vancomycin. And so that will require them to be inpatient. Complications would be bowel perforation, toxic megacolon, and may necessitate surgery. So postpartum headaches and associated conditions, there are common types, and there are chronic headaches. Patients may experience migraines, cluster or tension headaches, postpartum, similar to pre-pregnancy patterns. Migraine improvement is typically improves during pregnancy, but may recur postpartum. And it's especially linked to menstruation. So the concerns with a postpartum headache would be, the first one would be preeclampsia. A postpartum headache can signal the onset or worsening of preeclampsia. Immediate BP check, blood pressure check is essential. So if you go in the room, your patient says, I have a headache, she's like the lights bothering her and her eyes look low, go ahead and check her blood pressure, just to make sure that it's not, so you can rule that out, the possibility of preeclampsia. And you want to make sure it's not higher than, and this is always depending on what your per facility policy, but it's typically 140 over 95. Anything less than that would be less concerning for preeclampsia, but and there's also other things that would combine with that assessment as well, but that would be the way you could rule that out initially. Because if you report this headache to the provider, the first thing they're going to ask is if you've checked the blood pressure or vital signs. The thunderclap headache, that would be a sudden onset of headaches with or without neurological symptoms. The thunderclap term is what your textbook calls it. I have not heard that term used in practice, but it basically means just a sudden onset of a really bad headache is what I gathered from the textbook. It should prompt immediate reporting and imaging to rule out intracranial issues like a hemorrhage or vasoconstriction or cerebral venous thrombosis. indicate postpartum stroke, and it's a low absolute risk of ischemic stroke and cerebral hemorrhage during pregnancy. Risk increases up to 3-fold in the postpartum period compared to non-pregnant patients. So risk factors would be postpartum infection, hypertensive disorders of pregnancy, cesarean delivery, and your symptoms would be neurological deficits, severe headache, nausea and vomiting, and loss of consciousness. Postpartum angiopathy, that could be, it's rare, it's reversible vasoconstrictive disorder. So it's a severe thunderclap headache with a rapid onset in the first week of postpartum. Possible neurological symptoms: one-sided weakness, visual disturbances, numbness, seizures, speech difficulties. And the blood pressure may be normal or elevated with this one. Prognosis would be self-limiting, outcomes that vary, 50% full recovery and 22% mortality rate. Remaining may have neurological deficits. So they treat this with magnesium or calcium channel blockers, and they avoid glucocorticoids due to worse outcomes and rare recurrence in future pregnancies. We touched on this a little bit last week about the anesthesia-related headaches, and it's post-spinal headache due to leakage of the CSF fluid or the CSF and cerebral vasodilation. The characteristics would be positional headaches improve when lying down, worsen when they're sitting up. Non-positional headaches are unlikely to be post-spinal. So for that, it typically resolves in 7 to 10 days. Symptomatic care would be caffeine and analgesics, and then anesthesia may also place a blood patch, like we talked about last week. And for caution, headache with fever post-neuraxial anesthesia may indicate meningitis. And moving on to postpartum psychiatric disorders. So depressive mood disorders in pregnancy. There's postpartum blues, which is common. It's mild mood disturbances shortly after delivery. We typically tell patients that is normal, to expect those little bit of mood changes in those first few days, which would be postpartum blues. Postpartum depression is more severe. It's persistent depression occurring after childbirth. Postpartum psychosis is rare disorder affecting a patient's sense of reality. And then you've got PTSD that can occur during the postpartum period related to trauma experienced during or after childbirth. So if you've got a patient that has experienced delivery with instruments where they had a stat C-section, or shoulder dystocia, or something, baby had to be, there was a code after delivery. These are your patients that will probably experience some PTSD. So just being able to address that with them and let them talk through that and let them express their feelings surrounding their labor and delivery. So postpartum blues is transient. It's self-limiting mood disorder. It begins within 2 to 3 days after delivery and should resolve by 2 weeks. So the symptoms will be insomnia, fatigue, dysphoria, impaired concentration. So a lot of patients don't realize that they are experiencing the postpartum blues because they think, oh, I should be not able to sleep, I should be tired. But just talking them through that, letting them know that the reason why is because of your hormones. They're readjusting. It takes about a year for them to really get back to their pre-pregnancy state. And for postpartum depression, let's go back to postpartum blues. So the distinction from postpartum depression and postpartum blues would be it lasts longer than 2 weeks. And then postpartum depression is not self-limiting and has stricter diagnostic criteria. So postpartum depression is major depression occurring during pregnancy or within the first 4 weeks postpartum. And alternative criteria, the diagnosis may extend to onsets from 6 weeks to 1 year after birth. Okay, let's get through this because these are the last few. So postpartum depression overview, let's see. increased access. It can impact the whole family. So it's not just the patient. It can impact their children, their relationships with their family. You can look more into that slide when you go through the link. It's another chart you could look into. It just talks about different factors that can contribute to someone having postpartum depression. Let's see. So for assessment, there's an EPDS score that they'll do. You may see that in the postpartum unit when they, or you could ask somebody to look at an example of a EPDS. It's called the Edinburgh Postnatal Depression Scale. They do this routinely in the postpartum period. And then there's postpartum psychosis, and that's with hallucinations, disorganized thoughts, and delusions. It is a medical emergency if someone is in postpartum psychosis. And I have stories, but I'll keep going because we don't have time for those. And then understanding PTSD. So we talked about PTSD already. So a lot of patients experience this too if they've had like a fetal demise before they had their next baby. So a lot of times when you meet with these moms, their PTSD is so bad from that they can't get past or move forward with caring for the baby that they have now. So just being aware of that and helping them connect with the biggest thing for nurses is just connecting them to the resources and support that they need, making sure they have a plan. Advising to minimize stress. The biggest thing, like our perinatal mental health department tells us to make sure we advise them to get at least 4-hour increments of sleep, because the insomnia and the sleep deprivation is the biggest thing that contributes to postpartum depression and leads to postpartum psychosis, is because they don't have any sleep. But yeah, that's it. We won't have time for discussion, but yeah.
I know this is a lot, but I need to ask a question about, next week is homecoming. Homecoming, okay. But on Thursday, the alumni,